Okay, let's resume with some more clinical psychology. So, this is mood, also known as affective disorders, and we'll be talking about the different types of mood disorders, mainly your bipolar and unipolar depression, bipolar disorder and unipolar depression. We'll be looking at ways to measure depression and some of the causes, some of the explanations for these disorders, and how to treat them using psychological and biological management techniques. So let's see what the diagnostic criteria says for mood disorders. So these are basically the requirements or the criteria that needs to be fulfilled if one were to be diagnosed with having a mood disorder. So mood disorders refer to a group of disorders including bipolar and depressive disorder. Depressive disorder or depression is typically referred to as unipolar. Now, a pole has two opposite ends, right? You know there's a north pole, there's a south pole, right? Two complete opposite ends. So mood disorders, these are disorders that have to do with fluctuating moods. Now, just because someone is feeling a low mood or very high elevated mood does not mean that they are depressed or that they are going through a bipolar episode. You can have instances during the day, multiple times during the week where you might be happy or you might be really sad and low because of certain circumstances that may be going on in your life. That does not necessarily mean that you have bipolar disorder or that you have depression. Okay, like the previous chapters we've discussed for schizophrenia, for impulse control disorders, the difference between just having a low mood and being diagnosed with depression is the duration. And obviously the severity as well, but the duration is very important. And what is the duration that one must be experiencing a low mood for them to be diagnosed with depression? We'll take a look at that when we talk about unipolar depression. But the point I was trying to make was you have this, you have two poles. On one end of the pole, one extreme is a very euphoric and excited mood, which is what we refer to as a manic episode. And the exact opposite side of the pole is when someone is going through a very low, depressed, and almost like a hopeless state, a hopeless mental state, where they're feeling very sad, very low. That is classified as unipolar. So your mood can fluctuate between these two ends on the spectrum. So that is typically what we refer to as mood disorders. And they include episodes of particular types of mood over time, such as depressive episodes, manic episodes, mixed episodes, and hypomanic episodes. So we'll discuss each one of them in detail. Starting off with depressive disorder or unipolar depression. So anyone who's experienced depression would be familiar with these symptoms. It's characterized by depressive mood, which includes feeling sad, irritable, or empty. A person with depression typically no longer enjoys activities that they used to once find pleasurable. It's difficult for them to really find any pleasure in life. Um, Other symptoms can include an inability to function both mentally and physically. So you might find it difficult to concentrate, which obviously would affect your studies if you're a student, your work life, if you're employed somewhere. It would affect your relationships with friends, family, and so on. You will feel at times a sense of worthlessness or guilt, where you tend to blame yourself for anything negative that may happen in your life. You don't really see much hope in life because you view yourself as being quite worthless. And that can lead to, at times, recurrent thoughts of death, which is why a lot of people who are depressed um, can experience clinical suicidality, where they have suicidal thoughts. And more recently, changes in eating and sleeping habits or sleeping patterns has also been included as one of the symptoms of depression. And this does not mean that you only eat more and sleep more. It could be either you might sleep a lot or you might not be able to sleep at all. Similarly, some people, when they're depressed, they tend to eat a lot, they gain a lot of weight as a result, or it's the opposite where you just cannot eat. So these are individual differences. It depends from person to person, but there are definitely changes in your eating and sleeping patterns. So either it's extreme or it's very low, very minimal. In order to be diagnosed with depressive disorder, the individual can never have experienced a manic, mixed, or hypomanic episode, as these would indicate bipolar disorder. So, what is a manic episode? I explained briefly at the beginning that this is a situation where an individual is experiencing high levels of euphoria or excitement, elevated mood. It's basically the exact opposite of a depressive state. So, if you were to be experiencing, let's say, depression, and at the same time, you're constantly switching between depression and mania, manic episodes, that might be characterized as a mixed episode. And a hypomanic episode is a less severe version of a manic episode. So, if you've experienced a manic episode, if you've experienced mixed episodes or hypomanic episodes, and at the same time you are perhaps also going through a depressive episode, then we can't really consider that depression. So, the depression has to be all these symptoms we discussed in the first point: feeling sad, irritable, emptiness. So all of these in isolation. Okay, so it cannot be accompanied by manic or mixed or hypomanic episodes. Otherwise, that would then be bipolar disorder. You can have recurrent depressive episodes or single depressive episodes. A single episode is one where the individual experiences just one depressive episode without having a history of any previous depressive episode. So you haven't really ever experienced a depressive episode previously. You're experiencing one right now for a period of time. That is a single episode. A recurrent episode would be when there has been a second episode of depression, but it's not just a few days or weeks after the first one, but a couple of several months after. So you will only consider another depressive episode as a recurrent episode if it's many months after the first time you went through a depressive episode. If it's, you're going through a depressive episode and then a couple of days you don't have it, and then again you go through a depressive episode, that's still the same single episode. It won't be considered a recurrent episode. So it has to be separated by a period of several months. And how much time should you be feeling these symptoms for it to be considered depression and not just you going through a bad phase or just low mood? Because sometimes students don't do well in their exams. Sometimes you maybe getting fired from your job. So you might be going through a period of a couple of days where you're sad, where you're upset. During that period, you might feel extremely low. Obviously, the more severe the symptoms, then perhaps this 2 week period does not necessarily have to apply. But typically, for someone to be diagnosed with depression, you must be experiencing these symptoms for a period of 2 weeks. So if you've been experiencing these symptoms on most days for a 2 week period, then you can most likely be diagnosed with having unipolar depression. Okay, moving on to bipolar disorder. So this is the other extreme of mood disorders. Bipolar is, bi obviously means two, so it's talking about the two opposite ends of the poles, which is why it's not just mania, it also includes depressive episodes. And the combination of both would be a mixed episode. So let's talk about each one. Bipolar disorder are episodic mood disorders which refer to episodes of time where mood is either very high or very low. And you can have type 1 bipolar or type 2 bipolar disorder. Let's talk about type 1. Type 1 can include manic episodes and mixed episodes. What is a manic episode? So at least one manic or mixed episode. You can have more than one, but at least one manic or mixed episode. A manic episode is one where for a period of at least 1 week, the individual is experiencing extreme mood. So extreme levels of euphoria, very euphoric, very excited, at times even irritable. You have high levels of activity, high levels of energy. You can become impulsive, which can lead to you showing reckless behavior because all of a sudden your self-esteem is really high and it's behavior that is not typical or characteristic of you. You might even start speaking really fast. And this might be very noticeable to people around you, but might not be too noticeable to yourself. So this is typically a manic episode. Okay, it's a state of extreme euphoria, extreme excitement. And again, yes, you might be given some really good news. You got like three A's in your exams. You're extremely excited for the whole day. That does not classify as a manic episode. Okay? A manic episode does not necessarily have to be triggered by, good news. It can just occur randomly, and it has to last for at least 1 week, right? So feeling euphoric, feeling excited for most part of a day because something good has happened is pretty normal. But for 1 week, most hours during the day over a 1 week period, that's when it gets a little tricky. That's when it gets a little unusual. And that's when it starts reaching the level of it being characterized as a disorder, right? So that's a manic episode. A mixed episode is when a person experiences rapid changes between manic and depressive states on most days during a 2 week period. So within a 2 week period, a person is constantly switching between depression and mania. And if you ever met someone bipolar, you would notice this when they've experienced a mixed episode. You would see, I know someone, they told me about their experience. They were very sad. They were feeling, all those symptoms we talked about, emptiness, almost like they're feeling numb, loss of interest in any activity, um, perhaps even suicidal thoughts. And then all of a sudden, the next moment, the sudden rush of euphoria and excitement. So, you're going through two completely opposite states and it's switching. You're switching between these two opposite emotions for most days for at least 2 weeks. Okay, so you can have mood swings. Mood swings are different. Mood swings would be, you're angry maybe during the day and then later on you're happy. Um, but that's maybe like a day or two. That could be obviously hormonal reasons, hormonal factors at play, other factors at play. But when it's for 2 weeks and, it's not caused by maybe, let's say, for example, side effect of any medication or hormonal factors, but it's just something that is occurring more randomly for a 2 week period, having a significant impact on your mental and physical functioning, then this is most likely a mixed episode. And that will be, again, type 1 bipolar disorder. Type 2 bipolar is a hypomanic episode, not hyper, hypo. Hypo is a less severe version of something, a lesser version of something. So it's a lesser version of a manic episode, along with at least one depressive episode. So hypomanic episode is a less extreme version of a manic episode. So the person is going through several days of elevated mood or increased irritability, same as a manic episode, but not as extreme. And there is no history of mixed or manic episodes. So it's not just a manic episode. I mean, it is a manic episode, but it's a less severe. If it's a more extreme version, then it's not hypomanic. And it's quite obvious, so you'll be able to tell that this is quite extreme. Someone who's going through a manic episode, you can clearly tell that this is quite extreme. They become extremely excited, irritable, sometimes even hostile. So, it's very obvious. Hypomanic, little less severe. And no mixed episodes, which means you cannot be switching between hypomanic states and depressive states. So when it says over here, at least one depressive episode, it's not saying you're switching between depressive states and hypomanic states. It's saying previously you might have experienced depression, but now you're going through a hypomanic state. So you're not switching constantly between the two because that would then be a mixed episode. And then there are other types of mood disorders which don't typically fall under the main category of a mood disorder. We consider them more of um, changes in your mood states. Dysthymia is one. This is when a person experiences depressive symptoms for much of the time, but it never really reaches that level for it to be diagnosed as depressive disorder. So, similar to depressive symptoms over a long period of time, but not as severe. So, the severity is a lot less than depression, but the duration is more prolonged. So, because the severity is not that intense, it's difficult to to classify this as being depressive disorder. And cyclothymia is another condition, mood-related disorder, where an individual experiences numerous hypomanic episodes and depressive symptoms within a 2-year period. But again, over here, the severity of the symptoms are not as extreme, so it's difficult to classify these as bipolar or unipolar depression. Um, because in unipolar and bipolar, the symptoms are much more serious, much more extreme, much more severe. But the other difference is that these are more prolonged. So it lasts longer, but it's less severe. And because of the low severity factor, it's not considered to be bipolar or unipolar, but instead there are other forms of mood disorder. Okay, this here is a questionnaire, self-report psychometric, close-ended psychometric, that is used to measure depression. It's available online. You can search up the BDI-2. That's the updated version, which was developed in 1996. The original version did not include symptoms for sleeping and eating patterns, changes in sleeping and eating patterns. But as I discussed earlier, these are things that we now incorporate as part of symptoms associated with depression. So the newer version includes these two symptoms as well. So this is available online. You're free to take it if you want. You don't have to pay anything. It's pretty simple to take. Let's see how it works. It's called the Beck Depression Inventory, or simply the BDI. And like I said, the current version is the BDI-2, which was issued in 1996. It has 21 items, and it's a self-report. So the participants or the individual or the patient rates each item themselves based on what they feel within the past 2 weeks with respect to each particular behavior or emotion that is being assessed. So each of these 21 items would be different types of emotions or behaviors or states, mental states, for example, pessimism, optimism, sadness, um, what else? Eating, sleeping patterns, etc. So for each of these 21 items, the participant has to rate from a scale of 0 to 3 um, whether this applies to them or not. 0 typically represents, you know, less or no symptoms, whereas 3 is representing a very severe case of a symptom for that particular behavior or emotion. And you have to rate according to whether these apply to you within the past 2 weeks. Not today, not yesterday, but overall, if it applies to you within the past 2 weeks. Because remember, depression is if you've been feeling these states, these negative states within a 2 week period. So it's assessing symptoms of depression through feelings of guilt, hopelessness, other physiological symptoms such as fatigue, weight loss, etc. Each item is scored from a scale of 0 to 3, and then you calculate your overall score. The higher the score, the more severe, with a score of 14 to 19 representing mild depression, 20 to 28 moderate, and a score of 29 and above severe. Um, let's take a look at some examples. So these are just three. So take a look at the first one. It's on sadness. Within the past 2 weeks, rate yourself in terms of sadness. I do not feel sad. If you feel that within the past 2 weeks you do not feel sad, give yourself a 0. I feel sad much of the time within the past 2 weeks. If you feel this applies to you, then give yourself a 1. I'm sad all the time. If this is how you felt within the last 2 weeks, then give yourself a 2. I'm so sad or unhappy that I can't stand it. And if this is what applies to you, give yourself a 3. And just like that, you do the same for pessimism, for past failures, and for the other types of, or the other, all 21 items in this questionnaire. And then basically you just calculate your overall score, and then you see the scale, and wherever you fall, you can determine whether you have severe, moderate, mild depression. And it's quite useful because it serves as a baseline score. So, it can be used by your therapist to kind of get an idea of your level of depression. before beginning any treatment, for example, medication, therapy. So before any of that, you can get an idea of how severe your condition is. So you get like a baseline, a starting score. And then obviously over time, after treatment, after therapy, you know, antidepressants, whatever you opt for, you can take this assessment again, maybe after a few weeks or a few months, and then you can compare your scores to see if there has been any improvement in your condition or not. So before we start the explanations, let's talk about a few strengths and weaknesses of the BDI. So because it's a questionnaire, self-report, that too close-ended, it's got a couple of questionnaire-related strengths and weaknesses. So one strength is that obviously it's standardized, so it can be easily replicated by other researchers to test for reliability. It's got a scale from 0 to 3, which is quantitative, so you can compare results of patients over time. Like I just said, baseline scores can be compared over time to post-treatment scores to see if there's any improvement or not. So it's quite objective. A couple of weaknesses though. There's no qualitative data. So take for example, you know how you have this item on eating and sleeping patterns, right? What if one of the items that you're rating is that, you know, I'm not eating as much as I used to. I've lost a lot of weight. Maybe the reason for that is you're on a diet. So maybe that's got nothing to do with depression. But the scale will still go up, right? The score will still go up because you might be giving yourself a score of 2 or 3 for that particular item. But again, the reason does not have to be because it's a depressive symptom. But that's not something I will know because there is no qualitative data to tell me that. So because of the lack of qualitative data, there can be validity related issues. We don't understand the reason behind um, the patient's choice of a rating for each item. And secondly, with any self-report, there is always the possibility of socially desirable responses. What if some patients give themselves a higher score or lower score than what they're actually feeling? Maybe some people, for the sake of attention, want to give themselves a higher score. Maybe some people don't want to accept that they're depressed, so they give themselves a lower score. So obviously, if you don't give yourself an accurate score, then it'll be difficult for your therapist to treat you accordingly because they will treat you depending on the severity of your symptoms. But if you are over or understating your symptoms, the severity of your symptoms, then obviously it will lead to issues relating to the treatment. Okay, with that, we can now move on to the explanations part. And my cat has decided to sit on my laptop. So you'll have to give me 1 minute, like to get her off. Come here. Okay, she's off, but I got a beating on my hand for it. So, biological explanations. So explanations are split into biological and psychological. We should know that by now. Okay, we've done enough topics in clinical psychology. We've done 2 so far. ICD and schizophrenia have uploaded notes, and I'm sure you guys in school must have done many more topics in school. So you're probably aware now that you've got these 2 different types of explanations, biological and psychological. Biological will typically talk about the role of hormones, chemicals in the brain, such as dopamine, whereas the other type of biological explanation is genetic. That if someone in your family has it, what are the chances that you will also develop it? The role of particular genes, that could play a part in a certain disorder. So we'll start off with the biochemical explanation. So the biochemical explanation is looking at the role of these neurotransmitters or chemicals in the brain, such as dopamine and serotonin. Now, for this, we have to understand how our brain works a little bit. Our brain is made up of billions of cells called neurons, and messages are constantly being sent and received between neurons, right? So what I'm saying to you right now, you're comprehending it's because messages are being sent. You get hurt on your hand, a pain signal is being sent to a part of your brain. You're happy because you get good grades. A certain signal is being sent to the reward center of your brain. There's constant sending and receiving of messages um, from one neuron to the other in your brain. Similarly, you have these chemicals, dopamine and serotonin, which are also traveling from one neuron to the other. And these chemicals carry messages of euphoria and typically good mood. Serotonin, for example, is responsible for regulating anxiety levels, sleep, and dopamine is often referred to as a happy chemical. So these chemicals carry messages of happiness, good mood, and the idea behind the biological or the biochemical explanation is that people who have depression, people who are depressed, these chemicals tend to be in lower levels in the brain. As it says here, dopamine carries signals in parts of the brain responsible for feelings of motivation, pleasure, happiness, etc. These are feelings, these are behaviors that are typically low in a person who is depressed. And since this chemical is responsible for a person feeling these emotions, we can assume that someone with depression would, as a result, have low levels of dopamine in the brain. So when levels of dopamine are reduced, feelings of motivation and pleasure would reduce, which can lead to low mood, which, as we know, is typically a symptom of depression. And as a result of that, it can lead to a lack of interest in enjoyable activities. Now, what is the evidence for this? Research has found that people with depression, people with depressive disorder, they take antidepressant drugs such as MAOIs, which we'll talk about in the treatment aspect of this chapter, SSRIs. These increase the levels of dopamine and serotonin. And by increasing the levels of dopamine, it helps to reduce the symptoms of depression. Serotonin is another neurotransmitter, another chemical that regulates sleep, appetite, mood, anxiety. When these are normal, in normal amounts, normal levels, mood and anxiety levels are balanced. However, when they're reduced, it can lead to, again, low mood, anxiety, disruptions in sleep and eating patterns, all symptoms of depressive disorder. And the drug that is typically taken to increase the level of serotonin when people have low levels of serotonin, which can lead to depression, are called SSRIs. So this is a little bit of evidence that we have to suggest that these chemicals in the brain play an important role in a person experiencing depression. So lower levels of these chemicals in the brain can cause someone or can play an important role in someone experiencing depressive disorder. So that was the biochemical explanation. Let's move on to the genetic explanation. So under the genetic explanation, Kendler in 2006 in twin studies saw that there was a concordance rate. Remember from schizophrenia, concordance refers to the probability or the likelihood of twins sharing a certain trait. So over here, we found that MZ monozygotic or identical twins had a 44% concordance rate within females and only 16% in females who were DZ or non-identical twins. MZ or identical twins from schizophrenia, you should remember this term, are twins who share around, well, up to 100% of their DNA, which is why they're identical. But dizygotic or DZ twins are non-identical twins who share only up to 50% of their DNA. And the idea is that identical monozygotic MZ twins, if one twin has this disorder, what is the likelihood that the other will have it? For females who are identical twins, it's 44%. And for females who are non-identical, it is 16%. For identical male twins, the concordance rate is 31%. So if you are an identical twin and your co-twin, who's an identical twin, has depressive disorder, there is a 31% chance that you will also develop it if you're a male. And for non-identical male twins, it's 11%. Um, that's for depression. Let's take a look at what the concordance rate is for bipolar disorder. So for bipolar disorder, it's way higher for MZ twins than it is for DZ twins. 62% concordance rate. So if your twin and you're an identical twin, you're an MZ twin, if your twin has bipolar disorder, there's 62% chance you may also develop the disorder. And for non-identical twins, it's only 8%. So where the DNA is 100% the same, the genetic link increases, the heritability rate increases, the concordance rate increases. This is the genetic explanation. But there's another genetic explanation which we're going to look at, which is quite important. And this is the key study: association analysis of the 5-HT2C receptor and 5-HT transporter genes in bipolar disorder. This is by Orich et al. In 1997. This is a key study. Okay, it's a study conducted on patients with bipolar disorder compared to a control group of patients without any clinical disorder, or at least any mood disorder. And if you see just the heading, just the name of the key study: association analysis of the 5-HT2C receptor and 5-HT transporter genes in bipolar disorder. So over here, the genetic explanation is not looking at concordance rate, like we just looked at in the twin studies. It's not looking at the likelihood that if someone in your family has bipolar disorder, what are the chances that you will also get it? It's not looking at if your parents have it, what are the chances you will have it? That is genetic, but over here, genetic is being looked at from a different perspective. Over here, genetic refers to focusing on DNA testing, or rather, through DNA testing, focusing on two specific genes. And these two genes that we are going to be focusing on are the serotonin genes, the serotonin transporter and the serotonin receptor genes. So basically, the serotonin neurotransmitter genes are going to be focused on. And these are the genes that are responsible for regulating serotonin levels. Now, that is the focus of our study. Through DNA testing, we're going to be looking at these serotonin genes of a person in or a person with bipolar disorder, and we're going to be comparing their serotonin genes to a person without, or to people without bipolar disorder. And the name of these serotonin receptor and serotonin transporters, basically one that is receiving serotonin, one that is sending the message across from neuron to neuron, they are given codes because we have genetic codes. So you can refer to them, if you don't want to refer to them as the serotonin receptor gene, you can call it the 5-HT2C gene. And if you don't want to call it the serotonin transporter gene, you can simply call it the 5-HT gene. I recommend that you learn both, the name and the code. So let's see what it says. First degree relatives such as parents and siblings share around 50% of their DNA. This suggests that even mental disorders, just like physical illnesses, can also be hereditary, which means that there is a genetic link. You pass down from parent to child, sibling to sibling. There is a concordance rate, as we saw in the previous slide. Orich is looking at a genetic basis for bipolar disorder, and the aim of the study is to determine whether specific polymorphisms of two genes associated with serotonin transmission, which are the 5-HT2C and the 5-HT gene, were more common in people with bipolar disorder. So there's a key term over here that is forming the basis of the study: polymorphism. Big fancy word. Polymorphism is referring to a variation or somewhat of a mutation in the gene. And what does that even mean? If you take a look at the serotonin transmission genes, the serotonin transporter and receptor genes of people in the general population, there is somewhat of a similarity in the genetic makeup of these genes. If you take a look at this gene that is passed down from your grandparents to you, to your great grandparents, to your grandparents, to your parents, and to you, it's somewhat similar, right? Which is why there are certain similarities. This is responsible for regulating your serotonin levels. We believe, or at least Orich believes, that people with bipolar disorder, their serotonin genes have a variation, have a mutation, have a polymorphism. So their serotonin genes are slightly different to everybody else's. And that could explain why they are experiencing bipolar disorder. Because as we've discussed, serotonin has a role to play in mood disorders. So a possible variation, polymorphism in these serotonin genes could potentially be the reason why people have bipolar disorder. So, if I were to explain this in very simple terms, I always give this example. Think of a family recipe of a cake that your great grandparents created. That same recipe is passed down to your grandparents. They replicate it. It's the exact same cake, same recipe. That recipe is passed down to your parents. Exact same cake, exact same recipe. It's passed down on to you. You're using the same recipe, but you're making a slight change to it. Maybe adding a little less sugar to it, maybe adding a bit more flour to it, a bit more butter, maybe adding an extra egg, you know, just one or two slight changes. It's the same recipe, but the result is not exactly the same. There's been a variation. Imagine that same thing with the serotonin genes. A slight variation has occurred, a slight polymorphism has occurred, and that could result in the serotonin not being regulated in normal levels in the brain, which could potentially then lead to bipolar disorder. That is what we want to test. I'm not saying that is the case. I'm saying that's what Orich wants to examine, which is why she is going to be comparing a group of people with bipolar disorder to those without bipolar disorder. And through DNA testing, we're going to be examining the serotonin genes of the bipolar participants to the serotonin genes of the control group. And if we manage to find polymorphisms in the serotonin genes of the bipolar participants, and we don't find it in those of the control group, then we know that it clearly has a role to play in the onset of bipolar disorder. So this study was conducted on a sample of 42 participants who were diagnosed with bipolar disorder from 2 psychiatric hospitals in Croatia. 25 of the participants were female, 17 were male, and they were aged between 31 to 70 years. And they were compared to a control group, 25 males, 15 females, who did not have any personal or family history of mental health disorders, including mood disorders, and the sample consisted of hospital staff, friends, and family. The two groups are matched for sex and age. It's an opportunity sample. So a little bit about the sample, not very generalizable because they're all from Croatia. It's a small size and it's people with bipolar, so it's a limited sample. 16 of the bipolar group participants had at least one first-degree relative diagnosed with a major affective disorder, such as bipolar. So they're letting you know about the genetic heritability rate over here. So the bipolar participants, some evidence to suggest that it is genetic. We're taking a look at how many of these bipolar participants have family members with the same disorder. This information was collected from the participants and their family members and is also confirmed through medical records. Okay, then the DNA testing is going to be conducted to test for polymorphisms in two specific genes, the serotonin receptor gene and the serotonin transporter gene. This is for both the control group and the bipolar part. So over here, I've just explained what polymorphisms are. What are the results? Unfortunately, the results showed no significant association in the sample. So what was predicted was unfortunately not discovered. We didn't really find any association of polymorphisms in the serotonin genes to link it with bipolar disorder. However, in the sample, the only little bit of evidence that we did find suggesting that polymorphisms are associated with bipolar disorder happened to be sexually dimorphic. Sexually dimorphic means differences between males and females, other than your physical organs. So more like biological differences and hormonal differences, for example. So what we found is that polymorphisms were sexually dimorphic. Polymorphism association with bipolar disorder was sexually dimorphic, which means although we didn't find any clear-cut association between polymorphisms in these genes and bipolar disorder, the little bit of evidence that we did find happened to be more with the female participants than the male participants. This suggests that when we separated the participants and analyzed them separately by gender, trends for association with polymorphisms in female participants were observed, not so much in males, which means females are more at risk of developing bipolar disorder compared to males. So what we're basically trying to say is, although we did not find any association between polymorphisms in these genes and bipolar disorder, the little bit of evidence we did find happened to be in the female participants with bipolar, not so much in the males. And through that, we can predict that if we do find polymorphisms in these genes, particularly in females, we can predict that they're likely to develop bipolar disorder because we found a bit of evidence suggesting that in this study. Overall, no significant associations were found. And with that, we can move on to the psychological explanations, starting with Beck's cognitive theory of depression. So Beck is a very important person in this chapter. He's come up with the Beck depression inventory, and now he's repeated over here with his theory of depression. And he will come later again with a form of CBT treatment. So Beck's cognitive theory of depression in 1979 is based on the idea that depression in people is based on irrational thought processes. A person with depression forms a reality for themselves which is far-fetched in the perception of other people. So the way you perceive your life is a very negative one, it's a very negative perception, and for others it may be very irrational and unrealistic. And that might actually be the case because in your mind you are overthinking the situation to a point where you start to think of everything in a negative manner, and you start to associate any negative or negativity internally, which means you start to blame yourself for everything, which can lead to feelings of worthlessness and guilt. So this irrational form of thinking is referred to as cognitive distortion. Your thoughts are distorted. They're not rational. They don't make sense. Okay, it's not practical. It's not logical. And the reason why people have this very negative way of thinking, these distorted thoughts, this cognitive distortion, is the result of developing schemas. Now, schemas are developed through early life experiences, and they are our knowledge about the world around us, and they form our thought process. In very simple terms, to the way we analyze the world around us and how it makes sense to us. And it helps us perceive the world in a certain way. So people who have a very unpleasant upbringing, for example, who've gone through maybe abuse, violence at home, maybe where their parents and others have always blamed them for anything bad that happens, anything negative that happens, someone like that is very likely to develop negative schemas, which means develop a view of or the perception of the world or their world in such a way that everything is negative and they blame themselves for it. So that's their perception of the world. It's a very negative one. Someone with more positive schemas will view the world in a much more positive way, right? If you have a schema that dogs are harmful, every time you go to a dog, you'll be scared. But if you have developed a schemas that dogs are friendly, you'll go to a dog with more confidence because you'll trust it. So schemas are just the way you perceive the world and elements of the world around you based on whatever information that you have. And this information may not necessarily be correct. Because again, if you feel that everything is negative and it's your fault, that is an irrational way of thinking. And that can lead to you developing a negative view of yourself, which is this negative views of yourself. So this little triangle here is called the cognitive triad. And Beck is explaining how a person can develop depression through this cognitive triad. So because of your negative thought process, negative schemas, you tend to develop a negative view about yourself. I am worthless. As a result of that, you develop negative views about the world, which refers to how you perceive or how you think others see you. So you now think that not only do you believe that you are worthless, but you believe that others also view you as being worthless. So it's your perception of how you think the world sees you. And it's actually a reflection of how you see yourself. And that in turn leads to negative views of the future. Because I am worthless, because other people think I'm worthless, I'm never going to be successful in life. I'm never going to achieve anything great. I'm never going to get a good job. I'm always going to be worthless and useless. And you kind of get stuck into this triad, which leads to you developing depression. Learned helplessness and attribution style. This is the second psychological and the final explanation of mood disorders. This is by Seligman in 1988. It's based on the concept of learned helplessness, which is basically the idea that when you learn to endure unpleasant experiences, or rather, when you're going through unpleasant experiences and you can't get out of them, you learn to accept them. You learn to become helpless. You learn that this is your fate and there is no way out. So you're learning to become helpless and hopeless. And if an opportunity presents itself where you have a chance to escape this negative mindset, you have a chance to escape the negativity, you don't, because you've accepted that life is negative and you've accepted that it's hopeless and that you're helpless, and you almost embrace that negativity then. That can in turn lead to depression. And it can also lead to you developing what we call a negative attribution or explanatory style. An attribution style is how you attribute experiences, either internally or externally. So, for example, if you go through a negative experience, you might internalize it. You might attribute it to yourself internally, which means you will blame yourself for it. I am to blame. I am guilty of this. Someone who has a more positive mindset will have a different attribution style. If anything bad happens, they won't blame themselves. They will understand that it's possible that external factors out of their control are at play. And if something good happens, they will realize that they probably had a part to play in it. Whereas someone with a negative attribution style will not attribute it internally. They will probably think that, if something good has happened, it's just a fluke. It's, it's got nothing to do with me and it won't even last, because you've just learned to become helpless. So something is, good, you probably think it won't last too long, and then you just go back into a very negative mindset. So attribution style can play a very important role in whether you develop depression. So individuals develop patterns of thinking towards the world based on experiences that teach them to trust or distrust others. An individual who has had a difficult upbringing, such as experiencing parental loss, may be more likely to experience a perceived lack of control over negative events in their lives, hence leading to learned helplessness. So if you've grown up learning that you don't have much control over negative experiences in your life, you learn to become helpless. And this can then lead to you developing a negative attribution style, where you constantly view things in the future to be internal, stable, and global. So these are three very important parts of an attribution style: internality, stability, and globality. Internal or internality is when the individual attributes the negative event internally or to themselves, believing it is their own fault. Internal is when you're saying it's because of me, you're internalizing it. Internal means you, external means other factors. So if something bad happens, you might say, okay, let's take, for example, you fail a job interview, you don't get the job. A negative attribution style would make someone internalize it. I didn't get the job because I am worthless, I am useless, I am to blame. Someone with a more positive attribution style would not internalize this, but would rather not blame, but focus on external factors. Maybe I did a good job, but perhaps they hired someone who was more qualified. So it's not something in my control. I did my best. And guess who's going to be less likely to be depressed? Obviously, the person with the more positive mindset, with the more external attribution style, in this case, for positive life events, or sorry, for negative life events. Whereas the person who has a more internal mindset for negative life events is more likely to become depressed. So that's internality. Stability or stable is when the individual believes the situation will stay bad forever and will consistently be negative. So you did not get the job. That's, an experience that you went through, which was unfortunate. But stability is the mindset that you think this is always going to be the case. Every time that I apply for a job, I'm always going to fail it. I'm never going to get a job. So you're not thinking that this was just a one-time thing. You're thinking it's always going to be the case. That is stability. Someone with a more positive mindset would not think that way. They would think, okay, this was a one-time thing. Next time I'll work harder. Next time I'll get the job. So it's not always going to be bad forever. And globality or global means things are likely to go wrong, and more things are likely to go wrong and be negative. So this is just one aspect, one negative or one experience of your life, the job interview. Someone with a negative someone with a negative mindset will view other areas and other experiences of their life as also potentially being negative. So you didn't get the job, you will never get the job, but it's not just the job that I'm going to fail at. I'm going to fail at other areas of my life. I'm never going to get married. I'm never going to make any friends. I'm never going to earn enough money to support myself. I'm never going to, please my parents, for example. I'm always going to be a disappointment. So you are generalizing this negativity to other areas of your life, not just the failed job interview. That's globality. Okay, you're globalizing. Global means it's a broader perspective, so it's other aspects of your life. So other things will also go wrong, not just this one experience. Other things in your life will also be negative. So this is a negative attribution style. And a study was conducted by Seligman where he kind of wanted to predict how well your attribution style can or he wanted to test how well attribution style can predict depressive symptoms. So if you have a negative attribution style, you are perhaps more likely to experience depression. And if you have a more positive attribution style, you're less likely to experience depression. So he conducted a study on 39 patients with unipolar depression and 12 with bipolar, but the 12 participants were going through a depressive episode. So technically, all 51 participants at the time of the study are going through a depressive episode. They were all from the same clinic and included both genders with an average age of 36 years. And there was also a control group of people without depression, a non-clinical control group of 10 participants. So they don't have any disorder. All participants took the Beck depression inventory first, just so we can assess the severity of their symptoms. Obviously, the participants who are in the unipolar group and the bipolar group are the ones we're expecting to have a much higher score. And these 10 control group participants, we're not expecting them to get a very high score in the BDI. Then the participants filled out another questionnaire called the Attribution Style Questionnaire, and then they went through 6 months of weekly cognitive therapy. What is this Attribution Style Questionnaire? It's a questionnaire that has 12 items. Half of them are hypothetical good experiences, good events, and half of them are hypothetical bad events. For each good and bad event, for each of these 12 hypothetical good and bad experiences or events or situations, the participant has to give a cause or a reason. And I'll show you an example later. So you give a reason for, let's say they give you a positive experience, like my friend complimented me on my appearance. So that's a positive situation, a positive life event, a hypothetical positive life event. You now have to give a reason. Why did your friend compliment you on your looks? So someone with a negative attribution style would probably say something like, they were just trying to be nice to me because in reality I'm not looking good. But someone with a more positive attribution style would say, it's because I'm looking nice today. It's because I've dressed well today. That's the difference in thinking. After you've given this reason or this cause or this explanation for that hypothetical good event, you rate that cause that you've written down in terms of internality from a scale of 1 to 7, stability from a scale of 1 to 7, and globality from a scale of 1 to 7. Is the cause due to yourself or something external? Is the cause always going to be this way? Or is this just a one-time thing? And is this cause only applicable to this aspect of your life, or is it applicable to other areas of your life as well? Okay. What did the results show? That both bipolar and unipolar participants were found to have a pessimistic, negative attribution style compared to the control group. And the more severe their scores on the BDI, the worse the pessimism on the attribution style questionnaire. Those who had unipolar depression, who were undergoing therapy, had an improvement in their attribution style. They also showed an improvement in BDI scores over time after the therapy clearly showed that it was working. This is an example of one item from the attribution style questionnaire. So you read each situation carefully and imagine it's happening to you. Okay, that's step number 1. Read each situation carefully, imagine it is happening to you. This is the situation. You meet a friend who compliments you on your appearance. Decide what you believe would be the major cause of the situation if it happened to you. So write down, why do you think this happened to you? What is your reason for your friend complimenting you on your appearance? Write this cause in the blank provided. Answer 3 questions about the cause by circling one number per question. Do not circle the word. This is internality. Is the cause of your friend's compliment due to something about you or about other people or circumstances? So if it's totally due to other people or circumstances, you give yourself a 1. If it's totally due to me, you give yourself a 7. This is internality. Then you do it for stability. In the future, when you are with your friend, will this cause again be present? 1 to 7. And then globality. Is this cause something that just affects interacting with friends, or does it also influence other areas of your life? 1 to 7. So you do this for positive experiences, for negative experiences, and then you get an overall score. And based on your score, we will compare your score to we'll compare the scores of the two groups, and we will see who has a more negative attribution style. And those with a more negative attribution style also had a higher score in the BDI, meaning they were more depressed. So clearly, depression and a negative attribution style are correlated. And now we can do the last part, the treatment and the management. So we have the biological treatment, which is very similar to the biochemical explanation, in which we talked about the role of dopamine and we talked about the role of serotonin. And we said that these are in lower levels in the brain when someone is experiencing depression. So naturally, the role of biochemical antidepressant drugs would be to increase the dopamine and serotonin, to regulate them so that they're at normal levels. That's how antidepressants work. They allow for these chemicals to be regulated in normal levels in the brain so that your mood can improve. One type of antidepressant drugs are tricyclics. These were introduced in the 1950s and are still used today, and they're used when other forms of treatment have failed. How do they work? They increase the levels of serotonin and norepinephrine. Norepinephrine is another chemical that is associated with mood, and it's also typically low when someone is depressed. So all of these so-called happy chemicals, serotonin, norepinephrine, which is basically like adrenaline, which gets you excited, dopamine, these are all in low levels. Tricyclics increase the levels of serotonin and norepinephrine in the brain. What do? They stop these chemicals from being reabsorbed, which in turn reduces symptoms of depressive disorder. Now, what does reabsorb mean? I told you when we were talking about the explanations that dopamine and serotonin are in lower levels. But we didn't talk about how. We just said that they're in lower levels when they're passing through one neuron to the other. So let's do a little illustration to understand how that works. This is one neuron. This is another neuron. If you're a biology student, you would know that the space between two neurons is called a synapse. Let's say in this neuron, you've got your serotonin and norepinephrine chemicals, right? And they're carrying the messages of good mood and everything we discussed earlier. These chemicals pass through the synapse from one neuron to the other, and they reach the other neuron in specific areas of the brain, allowing your mood to be regulated in normal levels. For someone with depression, these chemicals get reabsorbed. So rather than passing through the synapse, what's happening is they're getting reabsorbed. And when they get reabsorbed, they're not passing through to other areas of the brain. And the only amounts that pass through are in much smaller amounts. So now the dopamine that is passing through is in rather not dopamine, but serotonin and norepinephrine, all these happy chemicals, they're in lower levels because they've been reabsorbed and broken down into smaller levels. So smaller levels are passing through. So that is why you experience depression. Tricyclics stop this from happening. They put a block over here, stopping the serotonin and norepinephrine from being reabsorbed, forcing it to pass through in normal levels, hence regulating your mood. So that's how tricyclics work. Let's move on now to the next one. They do have some side effects. I think nausea, constipation, drowsiness, etc. The next one is monoamine oxidase inhibitors. This is used to also increase the level of dopamine, norepinephrine, serotonin in the brain. And the way this works is, let's use the same illustration. So we've got a neuron here, we've got a neuron here. So you've got your dopamine, serotonin, norepinephrine. They're passing through the synapse from one neuron to the other. You have an enzyme in the brain. It's called monoamine oxidase. This is an enzyme. This enzyme is in this enzyme is basically working overtime in the brain of someone with depression. What it's doing is it's breaking down these chemicals into smaller levels. So it's coming here, it's breaking it down into smaller levels, which means when they're passing through in much smaller amounts in the brain, which is why the dopamine levels, serotonin levels are in lower levels. So this enzyme is to blame for that. Inhibit means to stop, to reduce, or to prevent. So monoamine oxidase inhibitors, the I is inhibit. That's the name of the drug. Monoamine oxidase inhibitors, or MAOIs. You can write the short form. These drugs inhibit or stop the role of this enzyme called monoamine oxidase. So when you take this drug, it's stopping this enzyme from breaking these chemicals down, allowing them to pass through in larger amounts. So it's inhibiting or stopping the the enzyme from breaking the chemicals down into smaller levels, hence allowing for the dopamine and serotonin and norepinephrine to be regulated in normal levels in the brain. So that's how MAOIs work. Okay, they too have some side effects. They've been used since the 1950s, have been known to have side effects such as headaches, drowsiness, insomnia, nausea, diarrhea, constipation. And withdrawal can also occur when stopped because people can become reliant on them and addicted to them. And these are best used for patients with atypical depression, which is when other types of antidepressants or other forms of treatments are unsuccessful, then you use these. And lastly, we have SSRIs, selective serotonin reuptake inhibitors. These are drugs that are specifically used just to increase serotonin levels in the brain. That's why they're called selective serotonin reuptake inhibitors. So reuptake means being reabsorbed. If you remember what we discussed in tricyclics, remember how the serotonin and how the norepinephrine was being reabsorbed into the neuron in the synapse and being broken down so it's in lower levels. So the tricyclics stop that from happening. SSRIs do the same thing, but specifically for serotonin, not for the other chemicals, which is why it's called selective serotonin reuptake inhibitors. It's stopping serotonin from being reabsorbed. And an example is Prozac. And they are most commonly used, they're the most commonly used type of antidepressants, as they have fewer effects than the other types, such as MAOIs. However, it's the way they work on people is different from patient to patient. Both forms, MAOIs and SSRIs, are more effective on patients with moderate to severe symptoms, but people with mild depression, not as effective. And they obviously also have side effects, but not as much as the others we discussed. So those were the biochemical treatment or the antidepressant drugs that were used for treating depression. Obviously, it favors the nature side. Deterministic in the way they work, but free will in the fact that you have the choice whether you want to take them or not. Application is high because it's a quick short-term solution, but also low because of the side effects and because it can lead to addiction and at times also individual differences, so it may not necessarily work on everyone. So it's more individual than it is situational. The effectiveness is definitely individual than it is situational. And it's reductionist because it's looking at just the role of these drugs in treating depression, but what about other forms like therapy, right? It's not really looking at psychological forms of treatment. Speaking of which, we'll talk about Beck's cognitive restructuring. This is a form of CBT, cognitive behavioral therapy. It's talking therapy between a patient and a therapist, where the patient is taught to identify their illogical and irrational way of thinking. Remember cognitive distortion? The therapist is creating awareness in the patient about this, that the way you're thinking, it's not logical, it's irrational. You, as a therapist, explain the cognitive triad to the patient. You help them understand how their own thoughts can lead to them developing depression because they're viewing themselves, the world, and the future in a negative manner. This helps them become more aware of the irrationality of their thoughts. The patient is encouraged to record any negative thoughts that they may have both at therapy and outside, write them down, and then discuss them with the therapist at the therapy and challenge these beliefs. Dispute, help them understand that the way you think can affect the way you feel and affect the way you behave. All of these are connected. There's a link between your thoughts, your emotions, and your behaviors. If you think negatively, you will have negative emotions, and as a result, you will behave negatively. So control your thought process, think more practically. If you're saying that, I'm worthless, I'm hopeless, no one likes me, question that, challenge it. Is that even true? The therapist will help you challenge it until you reattribute it. And you get to a point where you are no longer associating anything negative to yourself, but now you are understanding that there might be some things in life which are not going your way, which are not your fault. And that makes you blame yourself less, makes you feel less guilty about circumstances, and allows you to develop a slightly more positive mindset. And that is the starting point for you to get out of a depressive mindset. This allows the patient to change their thinking and realize a negative event may not be due to their own fault, but an external source. And once the patient is able to employ this cognitive restructuring for themselves, the therapy is completed because they no longer rely on the therapist to do this. And cognitive restructuring is particularly useful when drug treatment is ineffective or unsuitable because of side effects. And Wiles in 2013 did a study on 469 patients with depression, randomly allocated to either antidepressants or to cognitive restructuring. And those receiving cognitive restructuring had a 3 times greater improvement in their condition compared to those who were administered the antidepressants. So clearly a very useful treatment technique, a form of CBT. Another form of CBT is REBT, Rational Emotive Behavioral Therapy by Ellis. This is based on the philosophy that a person becomes depressed as a result of their perceptions and attitudes towards things that happen to them in their lives. So what causes depression to you is not necessarily some negative experience, but it is your perception of that negative experience. It's how you perceive negative experiences and adversities, and that can lead to depression. Take, for example, 2 students who haven't gotten a good grade in their exam. One student will be sad, both students will be sad, but one might be thinking, okay, you know what, I'll be sad for a day or two, but after a while, I'll use this as motivation to work hard, to do well, and I'll take a retake exam and I'll get a much better grade next time. So they're less likely to be depressed because they're thinking more positively. Another student with the same experience as them, same experience as the first student, bad grade, feeling sad, they may choose to think negatively. They may choose to think that this is the end of their life. They're never going to do anything good. They're never going to get into a good university if they're disappointed themselves and everyone else. And that can lead to them becoming depressed. So it's your perception of experiences in your life that can lead to you becoming depressed. And the REBT treatment is based on the ABC. ABC stands for activating event, beliefs about the event, and consequences. This is the part of the treatment where they're helping the patient understand how depression is caused. So we explain to you as a therapist that your depression starts with an activating event, a negative event in your life, negative experience. For example, unsuccessful job interview. That was the negative experience. You then have, as the individual who's experiencing that negative experience of the a negative situation of the unsuccessful job interview, you tend to develop a belief about it. Some people will have a more positive belief. For example, the student who said, I will use this as motivation to work harder. Some people will have a negative belief, which will be, I will never get anywhere. I am just not good enough. This negative belief will lead to negative consequences. And the consequences are your emotional and behavioral responses. You will feel sad, you will get angry, you will become frustrated, you'll become withdrawn from family and friends, you will refuse to apply for other work, and it's just a matter of time before you become depressed. So, negative experience, but it's the belief that determines the consequences. Negative belief will lead to negative consequences, which will lead to depression. So we explain to you how this ABC model can result in you becoming depressed. And then we move on to the treatment aspect. The treatment aspect is focused on disputing these negative beliefs, okay, challenging these negative beliefs. So if you think that the reason for or the result of you failing the job interview is you believing that you are worthless and you'll never get anywhere in life, we challenge these. Exact same concept in cognitive restructuring. The therapist will talk to the patient and we will dispute and challenge the rationality, the logic behind this, and make you believe that this does not have to be the case and you can think more positively. They help the patient understand they can have control over the way they think and feel about setbacks in their life. Patients must understand that consequences are only partly a result of the activating event, but their beliefs about the event can majorly affect the consequences and the way they feel about the activating event. So the treatment part is DEA. D is disputation, E is the new effect it will have after you dispute it, and A is acceptance. So disputing is referring to the process of disputing as discussed earlier. Patients are urged to dispute and challenge negative beliefs and think more rationally and optimistically and change their beliefs to more positive ones. So don't think negatively about the activating event, think more logically and positively about it. And when you do that, it'll have new consequences, a new effect. So now you're not going to be thinking, you're not going to be sad, you're not going to be frustrated or angry. Your behaviors, your thoughts, your emotions will be more realistic and more positive. But to ensure that this is more long term and not just temporary, you have to learn acceptance. So now that you're emotionally healthy, accept that reality might be pleasant, might be unpleasant. And there are three forms of acceptance that a person needs. Unconditional self acceptance is recognizing that you have good and bad aspects to yourself, to your personality. You are flawed, you're not perfect, but no one is. And just because you have flaws, that does not make you any less worthy than others. So don't think of yourself as worthless. So that's accepting you for who you are. Then there is unconditional other acceptance, which is accepting that not everyone will see you the way that you see yourself, if you're seeing yourself in a positive way. Others may not treat you fairly, others may perceive you, in a negative way, but other people's perception of you should not influence the way you perceive yourself. And finally, unconditional life acceptance is recognizing that life may not always be perfect and may not always go as planned. And there will be setbacks, there will be unpleasant experiences, but they will not last forever and they will not always be awful and unbearable. And eventually, the bad times will pass and they'll be replaced by good times. Because someone with depression does not see it that way. For them, it's always going to be bad. This unconditional life acceptance is a very important role. In fact, all three of these are acceptances that are very important to help a person to think more positively in the long run as well, so that there aren't chances of relapse and you going through another depressive episode. Now, speaking about the beliefs that we were talking about in the ABC model, this I'm only bringing up because questions have come previously on this in the past papers where they ask you outline two types of irrational beliefs. Right? There are irrational beliefs. The beliefs that people have about the activating event are irrational, they're negative, and that leads to you developing depression. This topic talks about a couple of these irrational beliefs that a person with depression could potentially have. One is awfulizing, believing that a negative situation will be awful. If I don't succeed, if I don't get the job, it'll be awful. So that's one type of negative or irrational belief, awfulizing. The other is low frustration tolerance, which is when you have a very low level of tolerance and you get easily frustrated and you say, I can't stand it if this happens or that happens. So that's another form of irrational belief. You don't have to get frustrated by anything by everything that does not go your way. Okay, that's not a very rational way of thinking. Self-downing is just, having low self-esteem, low self-worth, and considering yourself a failure. And the last one, which is a very strange term, masturbating. These are beliefs the individuals believe about themselves with regards to what they must do or have. So almost like setting certain, um, what's the word? Setting unnecessary pressure on yourself. That I must do this. I must get good grades. I must get this job because if it doesn't happen, I'll be a failure. So unnecessary pressure being set on yourself. So these are four types of irrational beliefs that a person can have, which can lead to negative consequences and as a result, depression. Is REBT effective? Well, Lyon and Woods in 1991 did a meta-analysis, which means looking at multiple studies where REBT was conducted, 70 to be precise. And these 70 REBT studies was giving us 236 results or outcomes, which were compared to baseline scores, compared to other forms of psychotherapy, compared to control groups. And they found that people receiving REBT had a much greater improvement in their condition from baseline scores, and it was more effective, or at least as effective as antidepressants and other forms of therapy. So this shows you that it's a very effective form of treatment. And unlike biological or biochemical treatments, antidepressants, the two psychological treatments that we've discussed, cognitive restructuring by Beck and REBT by Ellis, are more applicable in the long run because they teach the patient how to deal with the depression. Drugs just help you in the short run, but after a while, you might build tolerance. After a while, there can be other issues like side effects. There are no side effects when it comes to therapy. Yes, there are other problems with the applicability. Not everyone may be open to therapy. Cultural differences. In some cultures, therapy is seen as a taboo where it's not accepted socially. So people may shy away from therapy. Some people may not want a long-term solution. They may want a quick short-term solution. So they may prefer drugs. But one thing that this does favor is the nurture side, because in both cognitive restructuring and REBT, a therapist is teaching you strategies to dispute negative beliefs, to think more rationally and more positively. There is learning involved, there is free will involved. Okay. And it's more holistic because it's not only changing your thoughts, but it's changing your thoughts to change your behavior. So CBT, as we've discussed in previous chapters, is always relatively more holistic than biological treatments, but it is still reductionist in the sense that there is no drug use involved, there's no biological treatment involved, it's purely psychological. And they're all nomothetic because it's being done on larger groups of people. It's a generalization that we're making that this is something that's applicable to anyone and everyone with depression, that will work the same way with everyone. But the effectiveness can differ from person to person. So there can be individual differences, which would be idiographic, although there is no specific case study. So it's typically more nomothetic than it is idiographic. And on that note, we have completed mood disorders. For access to these slides, contact me on my details, which is, I think, mentioned on the first slide. Feel free to join my WhatsApp group. Link is in the description. And come back soon because I'll be uploading more videos. The next one I'm hoping to upload will be the structure and format for an evaluation for A2 psychology. So that's a very important video, very important lecture. So stay tuned for that. And then with time, I will gradually add more videos on clinical psychology. We've just got OCD and anxiety disorders left. And then after that, I'll move on to health psychology. Thank you guys. Hope this was helpful. Until next time, take care. Goodbye.